Hello and good evening. I am Dr. Sayan from Kolkata, and we are back again with our classes on medical physics for radiation oncology residents as well as for medical physicists. Uh, Today we have our class number 25. Previously, we had discussions on 3D CRT, IMRT, and stereotaxy as well. Today, it's time for image guided radiotherapy. And who else do we have for this class? Dr. Sayan Paul. He's one of the most popular radiation oncologists in India as of now through these because of his academic activities. Shayanda did his postgraduate from King's George College in Lucknow, and then during his senior residency, he has worked in several premier cancer centers that included SGPGI and Tata Memorial Hospital. Currently, he is working as a senior consultant at Apollo Hospitals, Hyderabad. So, Shayanda, it's now for you.
Thank you, Dr. Stein, for your kind words. And at the outset, I must thank Young Radiation Oncologist Club and many members of the Young Radiation Oncologist Club who have been working and hard to make our dream a success, to make this course successful. So I want to mention few names because I have got a chance today to speak, like Dr. Sayan Das, Dr. Jibak, Dr. Mukti, Dr. Tanvir Shahid, Dr. Santam, Dr. Rashi Agarwal, Dr. Anu Tiwari, Dr. Sizal, and so many others, Dr. Kanu Patro, and so many others. So I could not mention each and everyone's name. All have been involved from the beginning to make this course a success. And today is the 25th class. So 3 months course we had designed initially, and this is the last week. This week we will have 4 classes: today, Thursday, Saturday, and Sunday. And the physics course will be finished. And the course is archived in YouTube, and whoever wants to uh, check the course, wants to go back to listen to the course, they can go to our YouTube channel and they can watch all the lectures in YouTube. So today my topic is image guided radiotherapy. So, so let us start. 1 minute. Why it is? So a radiation oncologist is like a lioness, and before attacking the target, so it is planning. So it's plan like the lioness. We plan our GTV, and then why the slides are not moving. Then we plan our CTV, then we plan our PTV, and then we think that we'll be able to cover with our beam the entire PTV. That is the planning. And at the time of bouncing, the lioness, if the vision of the lioness is not good, if she has cataract in her eyes, she misses the target. And that can also happen with us if we can't see the target properly at the time of firing. So we miss the target and the cancer cells survives. We could not cure the cancer of the patient. So I know this is a bad analogy. So what I was trying to tell is you have to be very, very precise and accurate while delivering your radiation and while firing your beams. But it's a bad analogy. Why it's a bad analogy? Because radiation delivery is not like hunting. In radiation delivery, if you miss the target, you might damage a normal structure surrounding the target. So in any case, you have to be very, very precise and very, very accurate. So to be very precise and accurate, you need to adopt this technique called image guided radiotherapy. And in this process, you can see imaging comes multiple times. Imaging before planning, imaging before starting the treatment, imaging after starting the treatment. So imaging is one of the most important thing in radiation delivery. So for last few years, the story of development of radiation oncology has been development of our visualization of the target, like localization and seeing the target becoming better and better, and our accuracy and precision is improving day by day. So at the beginning, I want to tell that I will discuss the principles of IGRT. I will not discuss the details of individual machines and tools, because what I feel is, as a radiation oncologist, we should know the principle of image guidance. So like when you get a driving license, it is written that this person can drive a light motor vehicle. It is never written that this person can drive a Honda car or a Maruti car or a Mercedes Benz. It is the responsibility of the vendor who have manufactured the machine and the tools to train the user about their machines and how to use the machines. If you know the principle, you can use any machines. So radiation oncology, what we have been seeing for last 2 decades is more and more emphasis is being given on the machine and on the tools. Like a person is working in this machine, is not working in this machine. He or she knows the technique, and he or she, if knows the technique and principle, he can work in any machine with any tool. And I have never worked with Cyberknife, so my knowledge is also limited on Cyberknife. So, but I was telling about accuracy and precision. So this diagram you have seen multiple times, like what is accuracy and what is precision. In the first picture, all the 4 hits, 4 attempts hits the bull's eye. So it is accurate and precise. At the same position it is hitting and at the bull's eye. So in the second picture, though it is hitting the same position, but it is not on the bull's eye. So it is precise, but it is not accurate. So in the third picture, it is hitting near the bullseye, but all the four hits are not at the same place. So it is accurate, but it is not precise. And at the fourth picture, it is neither accurate nor precise. So you have to be accurate and precise. So what is the definition in Faizan Khan's book about image-guided radiotherapy? So I'll read it out. Image-guided radiation therapy may be broadly defined as a radiation therapy procedure that uses image guidance at various stages of its process. So, patient data acquisition, treatment planning, treatment simulation, patient setup, and target localization before and during treatment. In the present context, we'll use the term IGRT to signify radiotherapy that uses image guidance procedures for target localization before and during treatment. These procedures use imaging technology to identify and correct problems arising from inter and intra-fraction variation in patients, setup, and anatomy, including shapes and volumes of the treatment targets, organelles, and surrounding normal tissue. So the concept, I tell you, you are new generation radiation oncologist students, so it might not be a problem for you. But I have seen in many older generation radiation oncologists also, this concept is not clear. So as per definition, if we are using imaging at any stage of our planning or treatment delivery, we can call it IGRT, but actually it is not. So IGRT is when you are using image guidance to localize the target during the treatment, before or after. So why accuracy and precision is necessary? Why image guidance is necessary? Because radiation therapy is a proven local therapy. So if we can give precise radiation therapy, so we can reduce the severity and risk of therapy-induced complications, that is normal tissue complications, and we can increase quality and probability of success, that we all know. And there are some further potential, like we can broaden the application of proven therapies. Like suppose with precision therapy or with image guidance, we can increase the dose to a particular target and we can broaden the application. And it also permits new therapies that are intolerant to geometric imprecision, like SRS and SBRT. Without precision treatment planning and delivery, you cannot offer this treatment. So why we need so much of image guidance and precision during treatment delivery? Because there are many uncertainties involved in radiation treatment delivery. So what are the uncertainties? Can we set up variation? Can we internal organ displacement? Can we volume change and deformation? So there can be two types of variability. One is interfraction variability, variability between the two fractions, or it can be intrafraction variability. During one treatment fraction, there can be variations. So that can be setup errors, patient positioning errors, out of plan rotation, weight loss, non-rigidity, skin mark shifts, or it can be organ motions like volume change, deformation, bladder rectal filling, intra-abdominal pressure changes. It can be involuntary motion, can be bowel gas motion, respiration, peristalsis. Patient may feel discomfort and can move, or cardiac motions. So to encounter this, to encompass all these uncertainties, we give a margin which we call a PTV margin or a planning target volume. So you give GTV, CTV, and a margin for all these setup errors. It's a geometric margin. So remember, this PTV is a physics property. PTV is not a radiation oncologist property. So you give this margin for your errors and uncertainties. So you can edit your GTV, you can edit your CTV, but you can't edit your PTV. Or when the target moves, we give a margin called internal target volume margin that encompasses the entire range of movement of the GTV, and then we give a setup margin, which is the PTV. So before going to the details, let us see what are the movements or shifts the isocenter or the target can have during treatment. So there are 3 translational errors and 3 rotational errors. So translational errors are either longitudinal, that is craniocaudal, lateral, that is mediolateral, or vertical, X, Y, and Z axis. And there can be 3 rotational errors also. One is roll, that is rotation along longitudinal axis, can be pitch, that is rotation along lateral axis, and can be yaw, that is rotation along the vertical axis. So our aim is to minimize these errors as much as possible. So this formula, you all know, this PTB generation formula, Van Haag's formula and Strom's formula is 2.5 into systematic error and 0.7 into random error. This generally guarantee that there is a 90% probability that 99% of the CTB will be encompassed by 95% isodose. Assuming that the PTB is encompassed by the 95% isodose, if you give this margin. So what is systematic and random error? So how do you calculate it? So you get error in each direction for each fraction for the patient, the shifts that the imaging gives you. And you do an average for that patient, which is the systematic error for the patient. And when you do the standard deviation of all averages, you get the systematic error. And when you get standard deviation within a patient for entire fractions, like patient is getting 10 fractions, so we find out the standard deviation of this 10 fraction for one patient. And you have, that is your small sigma. And when you average all these standard deviations, you get random error. So by this formula, you can calculate PTV margins. So what are the image guidance technologies? So first generation image guidance technologies, we need to see, while we are planning, the imaging has developed a lot. From 2D planning, we have moved to 3D planning. But you need to remember that the radiation oncology treatment delivery is always 3-dimensional delivery. Rather, it is 4-dimensional delivery if you consider time. So whatever you do a 2D planning, you do a 3D planning, but treatment delivery is always 3-dimensional or 4-dimensional. So you need to see the target. You need to see the position of the target throughout the treatment to ensure that whatever you have planned is actually being delivered to the target. So to see the target during the treatment delivery, many types of technologies were developed, like ultrasound, KV radiograph, portal imaging, internal fiducial markers and matching, taking image and matching the markers. And then in second generation, KVCT, you put a CT scan machine inside the treatment room, or a MVCT, mega voltage CT scan like the tomotherapy, or a KV and MV cone beam CT scan. That is like our electrosynergy machine or variant onboard imagers. And the third generation may be this ultrasound approach called Clarity System. There is a KV CBCT approach, Mitsubishi, and MR guided. So I will not touch on these third generation image guidance technologies. I will mostly confine to first and second generation. So portal image, first one, because in Khan's book, it is written like this. So what is portal image? When you take an image through the same port from which port you are treating the patient. So it's the image of area being irradiated and is produced with the use of therapeutic X-ray beam. So it can be film-based or it can be electronic. So previously it was film-based, while we didn't have electronic portal imaging. So you need to develop the film and then see whether your isocenter is in position or not, how much is the shift you need to calculate. And that was like time consuming, and it was essentially offline because developing the film takes time. So you can't do any online correction. Online means before delivering that particular fraction of treatment. So electronic portal imaging is like there is an imager. So the mega voltage beam comes through the gantry head, the same gantry head of the treatment gantry head, and it is captured by a imager, that is image capturing device. So It captures the image and it sends the image, the digital image, to the treatment console room in our computer screen, and we can see the digital image. So the benefit is you can do online correction. The images you get immediately, and you can change the contrast and brightness of the image to see, to visualize it properly. You can match it with the digitally reconstructed radiograph or with the simulator image. What is DRR? DRR is a radiograph which is digitally reconstructed by the system from our CT scan dataset, planning dataset. So we actually do not take this radiograph, but the system generates this radiograph at the same isocenter point as of the portal image, so that we can match these two images at the time of treatment delivery. So there are many types of electronic portal imaging device: liquid ionization chamber, camera based, or amorphous silicon based. So usually you have to remember that whatever may be your field size, treatment field size, the portal image field size remains fixed. It's usually 18:8 or 10:10 at the isocenter. And we usually take anterior and lateral two films. For the first years, why you take two films? Because one film gives us two-dimension movements, shifts. Like in anterior film, you get craniocaudal and mediolateral shift, but you don't get the vertical shift. So in lateral film, you get the third dimension of shifts. So you can match it, you can superimpose it if you have that facility with your planning image, and you get X, Y, Z direction shifts. And then you decide what you want to do. You want to correct it on that treatment delivery, that called online correction. Or if you don't want to do it, you analyze the image after you deliver the first day's treatment. And if you find that the shifts are not acceptable, so then you can apply that, you can correct that before the second fraction. Or if you feel it is no, it's okay, then you can go ahead with your treatment. That is called offline correction. Then people thought that you were planning on a CT scan in a 3D image, three-dimensional image, and while delivering the treatment, you were matching a two-dimensional image. So the best matching will be a three-dimensional image with a three-dimensional image. So how can you get a three-dimensional image or a CT scan data set during treatment delivery? So the easiest way is to put a CT scan machine inside the treatment console. So that's called CT on rail. So as you can see, there is a CT scan machine, there is a LINAC machine, the axis is same, there is a table, there are two axes of rotation, one C1, which is the isocentric couch rotation, C2 is the rotation between the CT and the LINAC. So first you position the patient, the couch is rotated, the couch enters inside the CT scan moves inside and takes image, then you match the image, then again the table rotates and goes under the gantry head and you treat the patient. So this is at Memorial Sloan Kettering Center. Their CT on rail machine, and as it moves on a rail, it's called CT on rail. But there is some problem. Problem is that there is too much of movement for the patient, too much of movement for the couch. With the patient, the couch moves, goes inside the CT scan, and then again moves, rotates, and moves and goes inside the gantry head. So you remember, the more complex the process you make, there is more chance of adding uncertainties and errors. So, and more you move the patient on the treatment couch, there are more chance of adding errors. So, it is a time-consuming process. It takes time, and it's a cumbersome, complicated process. So the best solution is to attach a CT scan machine in the gantry head itself. How they can do it? This is a cone beam CT scan machine. It's a different kind of CT scan. I will explain what is fan beam CT and what is cone beam CT. And this CT scan X-ray machine, they have attached in the gantry perpendicular to the gantry head. So at 90 degree, there is a CT scan machine and the imager opposite to that at 180 degree. So it can, as you know, the gantry can rotate. So the CT, the cone beam CT machine can come to any position and take images at any position and without disturbing the patient. Patient is not moving, patient is lying on the couch comfortably, the gantry is moving. So when you think that you need to take image, you rotate the gantry, take image. And when you think that yes, imaging is done, analysis is done, you want to treat the patient, your gantry rotates and you can treat with the treatment head. So what is fan beam CT? Fan beam is like when this X-ray is coming like a fan in slices, like a normal CT scan machine. And the detector detects the X-ray, fan X-ray, and generates the image, like a normal CT scan. It's in slices. And what is cone beam CT? It is a volume CT scan. The entire volume is scanned in one rotation. And then the computer reconstructs the image digitally and gives you the slice by slice CT scan machine. So what is a fan beam KV CT scan? That is CT on rail or your diagnostic CT scan, and cone beam CT is the CT that is attached with the treatment machine. Few machines which have CBCT, like Elector Synergy and Variant Trilogy, the first generation machines which had CBCT. Actually, the Elector Synergy first incorporated CBCT, and then Variant also came up with their CBCT arm, which is called on-board imager. So, what are the strengths of KV cone beam CT scan? So, it is a radiometrically robust imaging it achieves and provides us for delivery of guidance and correction of shifts, and it does not change the patient position. So if patient position is changed, you add uncertainties and errors. And it's a three-dimensional image, so you match 3D image with a 3D image, and it is a large FOV, a 20 centimeter in length in a single rotation, and the image acquisition time is relatively rapid, like 32 to 100 seconds. And it gives you sub-millimeter geometric accuracy. And it provides high contrast radiographs compared to MV portal imaging. So the bones and the muscles can be appreciated better. So there is a potential of using contrast agents also, but we don't use contrast agents because you can't use contrast agents every day. But if you feel like that it's absolutely necessary, you can use it for once or twice. The imaging dose is low. For bone, it is 0.05 centigrade only. And for low contrast objects of tissue, it is 2 to 3 centigrade. And it is an independent imaging and delivery system. That means the gantry, which is taking the image, is not delivering the treatment. So in between treatment, if you feel sometimes that you need to check the position again, then you can stop the gantry, you can check it with the imager, with the CBCT, and you can again start the treatment. So it does not interrupt with it. So, and it also gives you online and offline guidance. That is obvious because it immediately gets the CT data set, which you can match with your planning CT data set, and also you can do it offline. And it can give you an idea of progression of therapy, like you are giving radiation to a particular area, whether the tumor is decreasing in size or it is increasing. Sometimes it may not respond to radiation and increase, and you can take action according to that. You can get a 4-dimensional CBCT. So we had a 4-dimensional CBCT in a electro access machine, and you can check in cine mode the organ motion. Like you planned something, planned an ITV, and you can actually check with the 4D CBCT whether the tumor during the movement is inside your PTV or going outside, PTV or ITV, whatever you say. And obviously the cost is 20 to 25 to 30% more than a conventional CT. And what are the limitations of cone beam CT? The image quality is not as good as a conventional CT scanner. Large volume of tissue is irradiated during imaging. The quality of KV cone beam CT images suffer from presence of X-ray scatter reaching the detector. This workload, because you take 5 to 10 minutes extra time for taking the image and matching and applying the shifts. And presence of clipping artifact for dental filling and other metal implants. If you take a mega voltage CT scan, these artifacts are less. The image quality can be improved if FOV is decreased, but sometimes you need to take a larger volume of scan. for matching. For larger FOB, there are artifacts, sticks and cup artifacts. So this is a typical CBCT. One minute, just a minute. Typical CBCT image. So in all the planes, sagittal, coronal, or axial planes, you can match with your planning CT scan. You can scroll, you can go to any plane and you can match in any plane, and you can actually see the tumor in the CT scan and whether the area which you want to treat, whether it is matching with your planning scan or not, you can do it. After matching, it gives you the shifts. It can give you translational and rotational shift, all the shifts, and you can apply it or you may not apply it according to your threshold or according to your protocol. So another thing you can do is, if you are using an internal fiducial marker, you can actually match the internal fiducial marker also with the cone beam CT scan and do image guided radiotherapy. The next one is mega voltage CT and the tomotherapy. This is our CT scan machine at Apollo Hospital, Hyderabad. Our tomotherapy machine, at Apollo Hospital, Hyderabad. So tomotherapy means tomogram and radiation therapy. So it was developed at the University of Wisconsin, USA in 2002. They had treated the first patient. And the principle of this tomotherapy is there is a linear accelerators attached to a ring gantry which rotates like a CT scan machine. And from the same gantry, I will confine to the imaging part only. From the same linear accelerator, you can take a mega voltage CT scan. So there is a detector array opposite to the linear accelerator which can capture the image and which can give a helical scanning and which can give a MVCT scan which you can match with your planning CT scan. So another benefit of tomotherapy is it can correct the roll error. Because it is in the ring gantry. So suppose there is a certain degree of roll, so the gantry also rotates to that angle and corrects the roll. And translational errors, obviously, you can correct with the couch. So same gantry head, though the energy is a bit less, usually it's 3.5 MV energy for the imaging and 6 MV is for treatment. So we don't need any port film or cone beam CT. Registration performed with an MVCT image on the KV CT from planning. It matches MVCT with KV CT. Imaging dose is 1 to 3 gray. So one problem with MVCT is the contrast is less. So between similar contrast tissues, there is a little less difference than a CBCT image. So what is the advantage of KVCT over MVCT? Because of more pronounced photoelectric absorption in the lower energy range, radiographic imaging with KV X-ray offers higher contrast. So greater visibility of bones and implanted markers, simplified interpretation of images, scanning time is less than MVCT, and lower imaging dose. Then there is another very interesting image guidance systems called exact track image guidance system. What is that? This is also called a stereoscopic image guidance system. This is very, very interesting. So there are two X-ray machines on the floor, as you can see, one in this side, one in that side. And two X-ray beams can be fired at 45-degree angle to the ground. And there are two ceiling mounted images which captures the X-ray and simultaneously takes two images in two oblique planes and gives you an oblique image. And the oblique image is matched with a digitally reconstructed oblique image which the system generates. And it gives you all 6 direction movements, the translational errors and rotational errors. So exact track image guidance is not only an image guidance system, it is also a positioning system. So how it helps in positioning? So there is here, as you can see, this is an infrared camera. So what you do is you put some infrared markers on the orbit or on the body of the patient, or you can attach it in a couch array or positional array or on a frame. So the infrared camera detects this infrared markers and actually gives you the isocenter position. So the system knows from your planning system. So you give an isocenter, give a coordinate, and with the infrared markers, the machine gets the coordinate of the isocenter. And it can guide you while you are positioning the patient, it can guide you whether you are at the isocenter or not. In this picture on the right hand side, you can see it is showing vertical, longitudinal, lateral. So when you are at the isocenter, it will show that, okay, you are just at the isocenter. Also the rotational errors also it is showing. It will show you that yes, you are at the isocenter, your positioning is okay. So you can position the patient without the help of lasers, without the help of skin marker. So every day you don't need to position the patient on the couch, match the skin marking or marking on the orbit with the laser, and then you take an image and match it. So it is a positioning system and also a verification system. So how it verifies? So it takes two oblique images, it matches with the DRR, that is oblique. And you need to remember that because these are oblique images and our knowledge of oblique anatomy is not good. So it is advisable to go for a autocorrect option. So automatically the machine corrects it and it gives you the shifts, all translational, rotational shift. You can apply the shift and treat the patient. So what is the benefit? Like the entire process takes very little time, around 10 to 20 seconds. You can actually get the image, you can match it automatically, and you can apply the shift. And another benefit is that while you are treating the patient, during the fraction, you can do an intra-fraction verification, which you can't do with other imaging modalities. Like if you want to do a CBCT, you have to interrupt the beam and you take CBCT and it takes like 5-6 minutes time and you again reposition and retreat and interrupt the treatment. But without interrupting the treatment, you can take images in between. And if you see that, yes, the intra-fraction variation is too much, you can take action also. So that is the benefit of exact track. Exact track also can match internal fiducials. So it can match bony anatomies, it can match internal fiducial. If we have put internal fiducial inside the target, it can match the internal fiducial and can give you accurate errors. And what is according to the vendor, it gives sub-millimeter accuracy. So another image guidance system, novel system is Cyberknife. So Cyberknife is quite similar to the exact track image guidance system. So here what happens is that like the exact track where X-ray sources were on the floor, here the X-ray sources are mounted on the ceiling. And there is in the floor, there is a X-ray image detector. So, and also there is a synchrony camera. They have some optical marker which keeps the position and coordinates. So the entire radiation oncology treatment planning and treatment delivery is actually coordinate geometry. You need to know the coordinate of your isocenter and match the isocenter coordinate with your planning coordinates, and then you deliver. So the more accurate in determining the coordinate or localizing the coordinate of the isocenter, the more precise and accurate treatment you can deliver. So it determines the coordinate of the isocenter, and then it takes images with the X-ray sources. And then here, one benefit is that the gantry is mounted on a robotic arm. So the arm can have 6-dimensional movement. So the arm itself can move into the proper position, and whatever shift it finds in the isocenter, the gantry itself can rotate, or gantry itself can move and come to a position to manage those shifts. So you don't need to move the patient, the gantry can move and gantry can actually correct those errors. So this is another picture. You can see the X-ray sources mounted on the ceiling and the detector here on the floor. So in exact track, the X-ray machine was on the floor, the detector was on hanging on the, was mounted on the ceiling. So it takes images like stereoscopic image and two oblique images, it matches and it gives you the shift. So these are the optical markers. With the optical markers, this stereo camera system, it can detect the optical marker and it can track the tumor. It also can track the movement of the patient or the isocenter. So how it matches with the DRR? DRR are automatically generated by the system. So from your CT data set, they generate the DRR, and the DRR is then matched with the image that is taken by the X-ray or the stereoscopic imaging system of the Cyberknife system, as you can see in this animation, and it is automatically generated and matched. So now there is another thing called hybrid system, like you incorporate 2-3 imaging system in one machine. Like you have a CBCT in a trilogy machine or a Novalis TX machine, and you add one ExactTrack machine with that. So the first hybrid system came with Novalis TX and ExactTrack, the variant system. And the second one with Electra machine synergy and access, ExactTrack was incorporated. And I'm lucky that I was a part of that team, but where the first this ExactTrack and Electra and ExactTrack combination, the hybrid system was installed in the world, that is in the Fortis Hospital. And I was there during this installation and their training program. So what it does so we also published 2 articles on validations of this integrated positioning system, hybrid positioning system. And I calculated the shifts and PTV margin of different imaging system in a hybrid online imaging modalities, and to check whether they are corroborating or not. So in hybrid imaging systems, you have multiple imaging options, like you have a portal image, you have MVCT image, you have CBCT image, 4T CBCT image, you have ExactTrack imaging, and you can use according to your convenience. And whenever you feel that you need the CBCT, you can do a CBCT. And if you need intrafraction imaging, image guidance, you can take ExactTrack images also. And if you want a 4D CBCT, you can take a 4D CBCT also. According to your need, you can use multiple imaging system. So now in most of the centers, they are using hybrid imaging, higher centers using a hybrid imaging system, because different systems are needed for different situations. So now the second part of the talk is target motion in radiotherapy. So as I had explained earlier, that the target is not static. When the lioness was bouncing on the zebra actually moved and lioness missed the zebra. So what we'll discuss today, types of target motion, the problem with target motion, and how do we deal with target motion. The target motion can be of various types, like for setup process, for organ filling process, and dose response process, or because of the breathing, the target can move. Target is mostly not static, except in a very rigid bony structure, like in the brain. In other areas, there is some kind of movement. So we need to manage this movement during treatment delivery. So there can be 2 types of organ motion. One is interfraction organ motion between 2 consecutive fractions. So change in average patient geometry of one fraction compared to the reference model at simulation. It can cause by organ filling, tumor shrinkage, or weight loss. And interfraction motion, within one treatment fraction, there can be movement or motion of the organ. So it usually changes the instant geometry caused by internal organ motion, like diaphragm, like lung and heart. So how much is the motion? It is actually significant. Like for lung, in published data, it can be up to 26 millimeter in craniocaudal, 8 millimeter AP, and left to right can be 2 to 3 millimeter. And for other structures like diaphragm, can be up to 25 millimeter, or in deep breathing, it can be 55 millimeters, quite high. For liver also, it is 2 to 3 centimeter. For kidneys also around 2 to 4 centimeter, pancreas also 2 centimeters. So there is significant movement, organ movement during the treatment. So what is the problem with the target motion? First one is you can miss the target. So if you don't want to miss the target, you need to increase the PTV volume. So which increases the dose to the normal tissues. So there can be interaction between the MLC motion and the organ motion, which can give you a non-uniform dose distribution, because nowadays we generate effluents by MLC motion. That is IMRT mostly we are practicing. So motion artifact during high-speed CT scan. So when you are taking image for your simulation, for your planning, you can get deformed image. So I will explain later. So when IMRT, it involves MLC movement over finite time period. And if the target moves during period, because each field compensates for other fields, it creates inhomogeneity. Suppose this is your planning dose, and if the target moves, so the delivered dose will be something like this. So you cannot afford the organ motion. You have to do something about the organ motion during your high precision treatment. Another problem is the simulation issue. So in a high-speed CT scanner, as you can see, these are the structures. If they are static, you get a representative image. But when these are not static, you can get deformed image. So C, D, and E are when the structures are in motion. When you take image, you get deformed image. And in the right side, as you can see, as the target is moving, in number 1, the section is different, and number 2 is missing, and number 4 in a different cut it is taking, number 5 in a different cut. So the image which you are getting is actually not correct. It is actually a deformed image. So this situation can arise when the target is moving, and in 2 CT slices you are capturing the same object. So resulting image, you get 2 images of the same object. And it can also happen that in first CT slice you miss the target, and as the target is moving in the second slice also you miss the target. So tumor is completely missed. So what can we do about the target motion? We can minimize motion artifact during simulation, and we can minimizing and correcting the interfraction motion, and we can try to correct the interfraction motion. So these are the management strategies. We can incorporate all movement, like we can take a 4D CT. I'll explain what 4D CT is. We can take slow CT. We can freeze the movement. So we can do a breath hold, like a particular phase. The patient holds the breath. We can freeze the respiratory movement, and we can treat at that time. Or we can intercept movement. We allow the person to breathe freely, and at a particular period only we can treat. That is called gated radiotherapy. Or we can track or chase the tumor. So we just chase the tumor where it is at that particular phase of motion, and we can treat chasing the tumor. I'll explain how you do it. So how we can limit the target motion? First one is breath hold, forced shallow breathing, or abdominal compression device. So you do use some device which dampens the movement, which reduces the movement. And you can allow free motion, but maintain a fixed target position in the beam side view. That is respiratory grating or beam tracking. This is the indigenous abdominal compression device we have developed in our center at Apollo Hospital, Hyderabad. So this is nothing but a packing material. We have cut it like this, and we place it under the diaphragm, and over that we place the outfit. So it compresses on the abdomen, and we have checked that this is the air equivalent material. We have taken a CT scan on of that material, and the house fluid is similar to the air, so it does not interfere with our planning or dose calculation, and it actually reduces the movement. So with the device, the diaphragm movement is 0.72 centimeter, where without the device, it is 1.47 centimeter. So first, with this device, you reduce the movement. And at the simulation also, there are motion artifacts we have already told. So you can use a slow CT scanner, like you can take image acquisition very slowly. So, but the problem is that you get a blood smeared image. And what ITB boundaries you get is an approximate. It is not exactly what reflects the movement of the tumor, motion of the target. or you can take a 4D CT scan. So 4D CT scan actually is the best to encompass, to take the image at every phase of the movement of the tumor. So you need to train the patient because this involves multiple tools, multiple machines. Patient should be familiar and comfortable. Patient should know actually what we are going to do with these machines, because if he is apprehensive, his breathing pattern will be different, with will not be normal. There will be deep breathing or shallow breathing, and it will not be reproducible. Then there are different ways to acquire respiratory trace. Like first, you need to tell the machine that this is the respiratory pattern. Then the machine will get to know, yes, the target is moving like this, and then we need to act accordingly. If we want to take image, we'll take the image like this, and with synchronously with the movement. So how we tell the machine that? We tell the machine the pattern of the movement. So there are different tools like Varian real-time positioning management, or called RPM. Elekta have ABC, active breath coordinator. Siemens has a belt. Philips has a belt or bellow on the diaphragm, and it tracks the respiratory motion, movement of the diaphragm. So how RPM getting is done? There is an infrared marker, and there is a camera, video camera. It captures the reflected lights, and it actually gives the respiratory pattern or generates the respiratory wave on the monitor, and machine gets to know, the imager, the CT scan machine or the treatment machine gets to know, yes, this is the respiratory pattern of the patient. So it can be voluntary breath hold, like patient holds their breath, usually at the end respiration for 12 to 20 seconds. And it's a monitor technique using a spirometer and transducer. And it's a patient has a screen or a video glass. Patient can see in real time how he is doing, his respiration is going, and he can hold the breath voluntarily. And during this time, you can acquire the image for planning. You can deliver the treatment also during the breath hold period. And we assume that during this breath hold period, the target, mainly the lung target, which is not moving, or it can be active breathing control, or ABC. The Elekta developed this ABC system. It's a spirometer-based system, similar in principle to voluntary DIBH, but the breath hold here is forced. When the patient enters the desired breath hold zone, a balloon catheter or a valve completely closes the air inlet, preventing the patient from breathing or for a predetermined period by the operator. So patient has a switch with which he can always stop the breath hold whenever is necessary. So it's a forced breath hold period. During the period, actually the image is acquired or the treatment is delivered. So there are several advantages. It reduces motion artifacts during CT scan acquisition, better delineation of target and ORRs, and allows reduction of internal margin, spares OAR, and deep inspiration, relative lung volume is less, and reduces cardiac volume during left tangential breast irradiation, like which is called DIBH, deep inspirative breath hold, which separates the heart from our PTV or CTV area, and with which you can spare the heart, and good patient compliance due to active participation. Disadvantages are it requires training of the patient. All patients are not suitable for DIBH, and reduction in lung density increases the penumbra width at the edges of the tumor, and possible underdosing that is missed by the EPS. These are the disadvantages. So now what is 4D CT scan? So you have given the respiratory pattern data to the CT scan. CT scan knows that, yes, this is the respiratory pattern or respiratory curve. Now in a 4D CT scan, for each position, for each slice, and for each breathing phase, you can determine in which phases you want to take the image. So you can divide the respiratory cycle into a number of phases, like 4 phases or 6 phases or 10 phases or whatever you want. So convey according to your convenience, and you tell the machine that I want image data set in each phases. So what the CT scan does it, in each couch position, like in each position, it takes images in each phases. So for one position, like in inhale phase, you get a CT data set. For a mid inhale phase, you get another CT data set. For mid cycle, you get another. For mid exole, you get another, and an exole, you get another data set. So you get a lot of image data sets. So for the same position in each phases of respiration, you acquire multiple CT scan images. And then they actually sort these CT scan images into different beams, like for different phases at particular phase, like inspiratory phase, mid-inspiratory phase. For each position, each mid-inspiratory phase, you get a data set. For end expiratory phase, you get a data set for the entire area you have image. Then you divide, you sort the images in different beams, and you tell the system what you want to do with the image data set. So and first, before going what we actually do with the 4D dataset, I tell you one or two things, that it takes the entire thorax about in 90 seconds. Radiation exposure is high than normal conventional CT scan as expected. So generation of individualized and usually smaller target volume derived from 4D CT scans in comparison to standard PTVs justify the addition of this extra radiation exposure. So what we can generate is, like in lung, we can generate an image called maximum intensity projection. So another thing is that what you can do if you want to contour the GTV or your target in different phases of respiration, what you need to do is you need to contour in each and every phase. So each data set. Suppose for a conventional CT, free breathing CT, there is only one data set you get, like you get 100 images. And if you acquire image in 4 respiratory phases, so you get 400 images. We have to contour in 400 images. So the system makes it a bit easier by generating these images when there is significant density difference exists between the tumor and the surrounding tissue, like the lung. So it generates the maximum intensity projection where it tells that, well, in each phases, this was the position of the tumor. So what you get, like this is the conventional on the left side, conventional CT scan, and this is a 4D CT scan. As you can see, it is significantly more. The size is significantly more than a conventional CT image. So it gives actually the entire range of motion of the tumor during acquisition of this 4D CT scan. So actually this is your ITV, because it gives you the entire movement of the tumor during the acquisition period or during the respiratory cycle. And you can generate the volume. In conventional, you give CTV and PTV. Here, you get a 4D CT data set, you get a MIP image, you generate an ITV, you give a setup margin for PTV, and you can irradiate. So this is one technique. So suppose if you don't have 4D CT scan, so can you generate ITV? This question arises because all centers don't have 4D CT scan. So yes, you can generate. How? You take one scan at deep inspiration, you draw the GTV, you draw the GTV in another scan which you have taken at deep expiration, and another GTV, you take a slow CT scan, you draw it on the slow CT scan. You can add PET CT data also, because PET CT acquisition is also slow. And then you take a free breathing scan, you draw the GTV, combine all the GTV, that makes your ITV, because it gives you the maximum movement a tumor can have. Because a deep inspiration and a deep expiration is the maximum movement a tumor can have. So one disadvantage is ITV is a little bigger than a 4D CT scan ITV. Because in normal breathing pattern, usually we do not take deep inspiration or deep expirations. So it's a normal breathing. The movement may not be as much as in deep inspiration or deep expiration. So ITV can be a little more. So you generate PTV and you can treat, but you can generate ITV and you can do SBRT. I have discussed this with Dr. Suresh Sayan, who is the father figure of lung SBRT, and he said, yes, obviously you can do by generating ITV in this method. So what is respiratory gating or breathing synchronized radiotherapy? So it can be external or internal gating. What you do is, you tell the system about the respiratory pattern. and you choose a gating window, and you treat or acquire your imaging data only at that window, and you treat the patient only at that window. So, so dose delivery is synchronized with the respiratory motion. So gating window is typically set when the patient is in exalt state where the target movement is least. There is a potential for dose escalation resulting in higher delivered dose to the tumor while healthy tissue is spared, and the correlation between internal and external motion we must know. So this is like the respiratory pattern, and the blue one is the gating window. So you treat the patient or you acquire your imaging data. So at which phase you acquire imaging data, you have to treat in the same phase. So you determine this is my gating window, and I will treat only when the tumor comes in this area. Or so you get a respiratory pattern, you tell the machine that yes, this is the respiratory pattern, and this is the window between which is synchronized with the machine. And when the tumor comes in this phase, only that time the beam is on, and when it goes out of this area, the beam is off. That is called gating. So to treat a particular area, you need to wait. The time is increased significantly because it treats when the tumor comes to that gating window. Again, it stops. Again, it starts treating when tumor again come to that window. So it takes a bit longer time for treatment. So this is the variant RPM. I already told there is a camera or illuminator. There is a marker block placed on the abdomen or at the diaphragm of the patient and tracks the movements and gives the information to the machine, gives the breathing pattern, and you tell the machine, well, I want to treat the patient in this window, and at that window only, you plan accordingly, and in that window only, the treatment will be delivered. The last one is a tumor tracking system. I'm already, it's 9 o'clock. So what is that? It consists of two major aspects. What is real-time localization of the target and real-time beam adaptation to a constantly moving target. So you localize the target during the treatment. It can be a room-mounted imager like Cyberknife or Mitsubishi RTRT system, or a gantry-mounted imager like Electa OBI or Varian IRIS, and you can adapt the beam. So move the accelerator like Cyberknife. It is mounted on a robotic arm. So it can move, it can track the tumor well. Tumor is here, it can move its position and treat the tumor. Or if the dynamic MLC can move, okay, tumor has shifted there, the MLC will move and will track the tumor and treat. Or the couch also can move. Couch also can move and come to a different position. If the tumor has shifted laterally like 1 millimeter, couch will move 1 millimeter and then you fire. So particularly important in radiosurgery to thoracic and abdominal tumor like in lung or in liver, where the movement is significantly more. So there is the newer systems like ultrasound-based 4D prostate tracking that is state-of-the-art US image quality. It does not require bladder field prostate imaging. There is a potential application in prostatectomy and gynae patients. The mechanical 3D probe operated remotely. Probe outside the radiation field. It is in the perineum. It detects the prostate. It gives the information to the machine, and the machine treats. I have never worked in this. This is there in, I think, the system is there in All India Institute in Delhi, and Dr. Harish uses this system. Whoever is interested can contact Dr. Harish. He is the best person, Dr. KP Harish, to tell you about the system. The last one is surface guided radiotherapy. This is the newest thing in image guidance. Here, there is a camera which actually takes the surface contour. It monitors the surface of the patient. The surface should be visualized by the system, and it can detect the movement. Like, it's simple. The camera can see the tumor, see the patient's surface, and it can detect whether the surface is moving or not. It has the coordinates and the machine, the isocenter coordinates, and it can actually tell, yes, the patient is moving or the target is moving, the isocenter is moving, and you can adjust accordingly. So IGRT, what according to them, is as precise as any other imaging systems, internal imaging system like ExactRang and other systems. By just monitoring the surface of the patient with a simple camera, it can actually do image guided radiotherapy. So there is a ceiling camera, the live reconstructor of high resolution IGRT surface. It reconstructs the patient surface and gives you in a reconstructed image. So there is a live registration of IGRT surface with the reference DICOM CT patient surface. Now, CT also get a surface, like it's the body contour of the patient. It matches the surface with that surface. It calculates the patient movements. It's a live calculation. Even during treatment, it can tell you that yes, the movement is like this, because it generates with the camera, it generates a body contour of the patient. It matches with the body contour that is generated by the CT scan, and it can continuously monitor whether the contours are matching or not. Okay, the only one thing is that the body contour should be visible to the patient. Like if you use a ORFIT mask, it will not be possible. Without the ORFIT mask, only you have to treat. You can use the other immobilization devices, and the surface of the patient should be always visible to the camera. So this is the surface guided radiotherapy. So this is the last thing, that is how much is the dose of different image guidance. That is also there in the Khan's book. There are some formulas. I'm not going into the details because I myself have not understood those formulas and I've forgotten mathematics completely. So CT on rail is 1.5 centigrade. KV CBCT is also 1.5. MV fan beam is also not more 1.5, but MV CBCT is a bit higher, 8 centigrade. And you can just check the images, different images, quality of images. So obviously the best image will be the CT on rail, that is KV fan beam CT, then KV CBCT. MV fan beam CT, the contrast is not that good, and MV CBCT is obviously the worst one. So thank you all. I want to acknowledge Dr. Kanu Patro, Dr. Shankar, Dr. Suman Malik, Dr. Sayan Das, and Dr. Tanvi Shahid, who has helped me for making this presentation. Thank you all, and we meet again on Thursday with another class. So thank you, Dr. Sayan.
Sayan, just a minute. There are a few questions.
Yes, please.
Okay, so we start off. So how are roll errors corrected in non-tomo machines?
Okay, non-tomo machine, if you want to correct rotational errors, you should have a 6D couch. So the couch should have the ability to correct the rotational errors. Like couch should be able to move in all direction. So normally the couch moves in X, Y, and Z direction. That only the translational direction. But a 6D couch can move in every direction. So it can move, correct the pitch, roll, and yaw. So if you have to see the couch once, if you see the couch, you will get to know that how the couch moves. So you need a 6D couch to correct it, or you can use a Cyberknife.
Perfect. What exactly is the added advantage ExactTrack offers in a hybrid system compared to KVCT alone?
Yes, the first advantage is very, very fast. Within 10 seconds, you get the image. So we did a small study and I presented it in ISTRO. So the study was time dependency and errors, time dependency of errors. I took intra-fraction images with ExactTrack. So during the treatment, I took image and we generated a model and we saw that for SBRT planning, if the treatment duration increases, the error increases. So you can be very, very, very conformal. You can generate a conformal planning, but your treatment time is like 20 minutes. During the treatment, the tumor moves. During the treatment, the tumor of the patient moves because it's uncomfortable for the patient. So patient can also move there to add more uncertainties. Time is a very important factor. And however conformal you be, at the end of the treatment, your uncertainties increases. So you can take intrafraction image, you can take image very, very fast with the same accuracy as a CBCT image. And also during the treatment, while the beam is on, you can take image. No other imaging technique can take intrafraction image. So that is the advantage of ExactTrack.
Very well said. So the next one is, what is your threshold for patients or the patient selection criteria for adaptive radiotherapy in the event of a tumor shrinkage or weight loss?
Okay, that is like adaptive radiotherapy. I have not discussed. Adaptive radiotherapy is a different topic altogether. It depends on, first of all, it depends on the institutional protocol, how much and also depends on the site. For head and neck, if you want to do some adaptive radiation, your threshold will be different, like in other sites. So it depends on the philosophy of the treating physician, depends on the site, and depends on the institutional protocol also. So threshold differs. I don't know if there is any standard protocol that for adaptive radiotherapy. There are many published papers, and like we did one thesis in our center, but there is around 20% difference in the volume. So we did a repeat planning or adaptive planning. So that is a thesis. That is a thesis protocol. That was a thesis protocol of one of our students.
Okay. So the next one is what's the difference between a slow CT and a routine CT?
Okay.
What's the
Slow
benefit of a
CT,
slow CT, and can we plan on a slow CT?
slow CT is slow acquisition. The normal CT is fast acquisition. Within few seconds, you take the entire body scan. Slow CT is in a particular couch position, the acquisition time is more. So the couch, if it is helical, the couch moves very slowly. So what happens is that during acquisition, the tumor moves. So it detects the movements of the tumor. But in slow CT, it can only help you or can guide you generating the PTB. Only on slow CT, you cannot generate. The images are blurred and it is not exact representation of the tumor movement.
Very true, because target delineation is very difficult on a slow CT because
Right,
the edges are so blurry.
right.
Why do streak and cup artifacts develop in a large FOV?
Okay, these are like when you increase, these are very, very technical things. Okay, so why it develops, there will be physics behind it, but I never bothered to know why it develops. Different artifact develops. If you increase the FOV, there will be many things will be playing, and I don't know why it develops. I only develop if you increase the quality deteriorate. If Dr. Sain, if you know, you can answer.
No, even my principle remains the same. I do not overburden myself with
Right, right, exactly.
information that is of no use to me.
Yes, if you are in doubt, you can ask your physicist. If he knows, he will tell you. Yeah.
Uh,
Yes,
is there any indication for using KV-MV combo in imaging? I
uh,
didn't get the question.
yes. Why you will do that? If you have a KV cone beam CT, you will do a KV cone beam CT. Why you will do a MVCT? Because you unnecessarily give more dose, more imaging dose. Your imaging image is not also good.
Yeah. Next is what is the usefulness of post-treatment imaging? I didn't get the question. Post-treatment imaging of what?
Oh, probably what he is saying that there are many articles published. Okay, they wanted to check the interfaction error. So what they do is they take an image before the treatment and they take an image after
Ah,
completion
okay.
of treatment, and they then you can calculate during the treatment how much the patient has moved, how much the ICU center has moved. That you can determine with that. So from initial, all the CBCT data for interfaction movement are based on this. So you can determine interfaction movement, but it is not actually it actually does not tell you interfaction movement, because when we plotted the interfaction movement with exact track, it is variable. Sometimes it moves in plus direction, sometimes it moves in minus direction also. And at the end, there might be no movement. But during the treatment, in 10 minutes time, there might be 1 millimeter movement to the right, then 1 millimeter movement to the left, and at the end, there may be no movement. Or at the end, there may be 1 millimeter movement, but actually during the treatment, there was 1 millimeter movement to the opposite direction. So that's what I feel.
Okay, okay. In case of breath hold technique, why is radiation administered after a deep inspiration?
Okay, at the deep inspiration, what happens is that the chest wall and the heart separation increases because there is more air in the chest wall, so it expands. So heart remains in its position and chest wall goes out. So the distance between the chest wall and heart increases. So if you plan in this DIB, deep inspiratory breath hold position, you can spare the heart mode. You can reduce the dose to the heart. For left-sided chest wall or left-sided breast irradiation, it should be routinely done, EIBH, to reduce the dose to the heart.
Okay, perfectly answered. If I just add one more point, when it comes to treating the lung, uh, we usually, especially if you're planning for respiratory gating, we usually prefer the end expiratory phase because there the movements are the least.
Yes,
Uh, the counter argument is you tend to treat more lung tissue because it is more dense. When you
right,
do a end
right.
inspiration, there is more air, so less lung
Yes,
tissue is irradiated.
yes,
But again, the counter to this argument is that so when there is more air spaces, the particles have a more penetration, leading to more doses to your normal lung. So the
right,
convention
right,
is you treat during the end expiration.
right.
Okay. Any other questions? Uh, Shanta must say it was a brilliant
But
class,
in
very well explained.
breast it is DIU, deep inspiration.
Yes, 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 definitely.
Right. So
Very well explained, no doubt.
thank,
Thanks a lot. Thanks a lot.
thanks and thank you all and good night. So you can
Yeah,
end the session.
yeah.
Okay,
So that's all for today. Good night and goodbye.
bye.